So you're walking down the hall, just, doing a routine rounding check, and you step into a patient's room.
And instantly your stomach just drops.
Oh, completely. You're hit with this massive, pure adrenaline spike because the patient in front of you is actively seizing.
Yeah, and it's the very first time you're seeing this happen in real life. It's terrifying.
It really is. I mean, textbooks do a thorough job describing the clinical phases,
Yeah.
right? The stiffening, the jerking.
But reading about it in a quiet library does not prepare you for the sheer intensity of that moment at the bedside.
Not at all. The sounds, the speed, just that overwhelming feeling that you have to do everything all at once. For a nursing student or a new grad, it just feels incredibly intense to have to switch from observation mode into like high gear, life-saving clinical action.
Oh, the gap between the textbook and the bedside is massive. Because in a split second, your brain is trying to process a neurological emergency while your own sympathetic nervous system is just screaming at you to panic.
Right, and channeling that very normal rush of fear into precise clinical judgment is, honestly, the hardest but most vital transition a new nurse makes.
It absolutely is.
So, welcome to an episode of the Super Nurse Podcast, created by Brooke Wallace. Now, for those familiar with Brooke, you know she is an absolute powerhouse. She's a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author.
But just to be completely clear right out of the gate, we are not Brooke Wallace.
We are definitely not. But this entire conversation is built directly from her extensive bedside knowledge, her clinical notes, and, her signature teaching style.
Exactly. Our mission today is to help you take what you are memorizing for the NCLEX and actually apply it to real-world patient care.
Yes. But before we get into the clinical gold, we want to warmly invite you to subscribe and watch the video version of this episode on YouTube. The link is in the description for our channel, Super Nurse AI.
You'll definitely want to check that out, especially for these highly visual, bedside-focused topics.
For sure. So taking textbook knowledge and turning it into bedside confidence is what we're focusing on today.
We're looking at what the NCLEX actually wants you to know about seizures, why it matters when those monitors start alarming,
Right.
and, the exact step-by-step clinical judgment required to keep a seizing patient safe.
I remember learning the textbook phases of a seizure in school, but standing at the bedside, it's rarely that clean. Like often a patient doesn't just spontaneously start convulsing without any warning, right?
Right.
So what are the earliest clues we should actually be looking for before the physical seizure even begins?
Well, the earliest clues often show up in what we call the prodromal phase, and this can happen hours or, honestly, even days before the event.
Wait, days? Like that early?
Yeah, days. Clinical experience shows this usually manifests as a really subtle change in baseline behavior. A normally calm patient might become inexplicably irritable or maybe depressed or confused.
I feel like that's so easily missed or just brushed off as hospital delirium.
Exactly. It's very easy to miss. But the much more immediate and specific warning sign is the aura.
Ah, the aura. That always fascinated me in nursing school because the presentations are so bizarre. Like a patient might look at you and say they suddenly taste metal or they smell burning rubber.
Or they have a profound feeling of déjà vu. It's wild.
Yeah. Pathophysiologically, what is actually happening in the brain to cause those highly specific hallucinations?
So an aura is essentially the brain's early warning system. It represents a localized electrical misfiring.
Okay.
Before the electrical storm spreads globally across both hemispheres, it often starts in a very specific, localized focal point.
Like a starting block.
Precisely. And if that focal point happens to be in the temporal lobe, well, that lobe processes auditory and olfactory information. So the patient is going to experience sudden phantom smells or sounds.
Oh, that makes so much sense. And if the misfiring starts in the occipital lobe, they might see flashing lights.
Exactly. It's an altered sensory perception based entirely on the anatomical starting line of the seizure.
So, practically speaking, if I'm standing at the bedside and my patient suddenly grabs my arm and says, I taste metal and I feel really weird, how long do I actually have before that localized misfire becomes a full physical convulsion?
You have an incredibly brief window, usually just seconds.
Just seconds.
Yeah.
Yeah.
You do not have time to go check their chart. You don't have time to log into the computer. And you certainly don't have time to run down the hall to ask the charge nurse for advice.
Right.
If a patient reports an aura, your immediate #1 bedside priority is protecting them from gravity.
Because if they're standing in the hallway or sitting up in a chair when they lose consciousness, the secondary head injury from falling could be well, far more devastating than the seizure itself.
Exactly. You ease them safely down to the floor, or you assist them into a side-lying position in bed. You are actively mitigating the physical risk before the active ictal phase begins.
Okay, let's follow that progression then. The window closes, they lose consciousness, and we enter that active ictal phase. The classic presentation we see tested on the NCLEX and often see in the ICU is the generalized tonic-clonic seizure. First comes the tonic phase, which is that rigid stiffening of all the muscles.
Yeah.
And this is accompanied by a sound that genuinely terrifies new nurses. The patient lets out this sudden, loud, guttural cry. It literally sounds like a scream of terror.
Oh, the ictal cry. Yeah, it's awful to hear.
What is actually happening there mechanically? Because it freaks people out.
I mean, it's entirely mechanical. It is not a response to pain.
Okay, that's good to know.
Yeah. During the tonic phase, every skeletal muscle in the body forcefully contracts. So when the muscles of the chest wall and the diaphragm violently spasm, they compress the lungs.
Which forces all the trapped air up and out.
Right. Out through the vocal cords, and
Sure.
it produces that ictal cry. It's a startling sound,
Right.
but understanding the biomechanics helps you stay calm. They're not in pain. They're completely unconscious.
So following that initial stiffening comes the clonic phase, which is the rhythmic, violent jerking. At this point, the patient might become severely cyanotic, turning blue around the lips. And you'll often see urinary or bowel incontinence because sphincter control is just completely gone.
Totally gone.
In the middle of all this chaos, human nature makes you want to run and get the expert, you know? You want to sprint out of the room and grab the attending physician. Why is that the ultimate NCLEX trap?
Oh, man. Because leaving the room violates the absolute non-negotiable golden rule of seizure management.
Yeah.
You never leave an actively seizing patient.
Never.
Never. The NCLEX will offer you multiple choice options that sound perfectly reasonable, like leave to grab the emergency medication or go find the charge nurse.
They always try to trick you with those.
They do. But if you select those, you fail the question.
Sure.
And in actual practice, you put the patient in grave danger.
Mm-hmm.
In that moment, you are the expert the patient needs.
Right. So you hit the call bell, you yell into the hallway, you make as much noise as necessary to bring the rapid response team to you, but your feet stay planted next to that bed.
Exactly.
Yeah.
Because if you leave, they could aspirate, they could thrash themselves right out of the bed, or their airway could become completely compromised.
Which brings us to the hands-on interventions. So we're planted at the bedside. Airway and breathing are the priority, obviously, so we guide the patient onto their side.
Yes.
But I think we often gloss over why the side-lying position is so crucial. We treat it just as a memorized step rather than, actual physics.
Right. It really just comes down to basic plumbing and gravity. During a seizure, autonomic overload causes the patient to produce massive amounts of excess saliva, and they might vomit.
And because they're unconscious, they have completely lost their gag and swallow reflexes.
Exactly. So if they are flat on their back, gravity just pulls all those fluids straight down the trachea into the lungs. That causes aspiration pneumonia.
But by turning them onto their side.
Gravity works in your favor. The fluids drain safely out of the mouth and onto the pillow. You are mechanically protecting the airway.
Okay, while we're protecting the airway, we have to talk about the most persistent, dangerous myth in seizure management, the tongue blade.
Oh, the tongue blade. Please, let's talk about this.
We see it in movies all the time. Someone's stuffing a wallet, a spoon, or a wooden stick into a seizing person's mouth to prevent them from, quote-unquote, swallowing their tongue. Let's break down the biomechanics of why that is a catastrophic nursing error.
First of all, it is anatomically impossible to swallow your own tongue. It just doesn't happen.
Right.
Second, during the tonic phase, the master muscle, the muscle that controls the jaw, is contracting with maximum uninhibited force.
And that is a strong muscle.
It's one of the strongest muscles in the human body. It's capable of exerting incredible pressure. If you attempt to pry a seizing patient's jaw open to insert a plastic airway or a tongue blade, you will shatter their teeth.
That's horrifying.
It is. And then the patient will aspirate those broken tooth fragments directly into their lungs. Furthermore, they can easily bite your fingers down to the bone. So keep your hands and all objects completely out of their mouth.
Okay, duly noted. So it's all about proactive safety rather than reactive scrambling. This is why seizure precautions are heavily emphasized on exams and on the floor.
Absolutely.
I like to think of it as setting up your mise en place in a kitchen or a pilot doing a pre-flight checklist. You do the work before the emergency strikes.
Yeah, you absolutely do not want to be untangling suction tubing or searching for an oxygen flow meter in the supply closet while your patient is actively turning blue and convulsing.
That's a nightmare scenario.
It really is.
Hmm.
Being ready for business means the Yankauer suction is already hooked up, the canister's on the wall, and the vacuum actually turns on when you test it.
Right, and you have supplemental oxygen, like a non-rebreather mask or an ambu bag, connected and ready to go.
Exactly. You also pad the side rails, so if they thrash against them, they don't fracture an extremity. You lower the bed to its lowest possible position, and you push the bedside table and any hard furniture completely out of the way.
Okay, so during the actual clonic jerking, what is the protocol for restraining those flailing limbs? Because the instinct is to hold them still.
The protocol is you never physically restrain a seizing patient. Ever.
Good to reinforce.
Yeah, if you try to pin down a clonic spasm, the opposing forces will cause severe muscle tears, dislocated shoulders, or even bone fractures. Your job is to guide the movement safely, not stop it.
So you protect their head by sliding a soft pillow or folded blanket underneath it, and you just let the seizure run its natural course.
Yes, exactly right.
Okay, so they're safe on their side, gravity is helping, and the bed is padded. We're protecting the physical body, but we also have to watch the clock. How long can the brain sustain this electrical storm before we have to intervene chemically?
Well, clinical experience shows that most unprovoked seizures are self-limiting. They run their course in about 1 to 3 minutes.
Okay, 1 to 3 minutes.
Yeah. The brain eventually exhausts its electrical surge, the inhibitory pathways take over, and the seizure stops. Noting the exact onset and duration on your stopwatch is critical because, as we say, time equals brain tissue.
Right. But what happens when that stopwatch hits 5 minutes and they are still actively convulsing?
Crossing that 5-minute mark, or having multiple seizures back-to-back without regaining consciousness in between, means the patient has officially entered status epilepticus.
Oh, status. Let's paint the bedside reality of status epilepticus, because this is not just a prolonged symptom, it is a code-level medical emergency. What is happening pathophysiologically during status?
Think of the brain as an engine that is redlining without any coolant.
Ooh, great analogy.
Thanks. For 5 minutes, that engine has been firing at maximum capacity. It's burning through massive amounts of glucose for energy, it's generating metabolic heat, and it's producing lactic acid from the continuous muscle contractions.
And simultaneously, because the diaphragm is compromised from the seizing, the brain is being starved of oxygen.
Exactly. The brain's normal inhibitory mechanisms, specifically the GABA pathways, that usually hit the brakes on a seizure they've completely failed. The body cannot stop this cycle on its own.
So without intervention, what happens?
The physical structure of the brain tissue begins to sustain irreversible permanent damage, and the severe hypoxia can lead directly to cardiac arrest.
Wow. So, as the nurse, you've already called the rapid response team. Now, you must anticipate the immediate next steps. You prepare for endotracheal intubation because the respiratory drive is failing and the airway must be secured.
Yes, absolutely.
And you are calling the provider for heavy pharmacological intervention. Now, when a patient is turning blue and the seizure isn't stopping, the instinct for a newer nurse might be to push whatever maintenance seizure drug the patient is already prescribed, like their daily dose of Keppra.
Oh, yeah.
Why is that the exact wrong move in status epilepticus?
Because pushing a maintenance drug during an active crisis is like throwing a slow-release capsule at a roaring house fire.
Okay, that makes sense. It's too slow.
Exactly. Maintenance anticonvulsants take time to build up therapeutic levels in the bloodstream. In status epilepticus, you need drugs that are highly lipid-soluble, meaning they can cross the blood-brain barrier instantly.
Right.
So we use fast-acting intravenous benzodiazepines.
The PAM and LAM drugs, like lorazepam, which is Ativan, diazepam Valium, or midazolam Versed. How do they actually stop the seizure so quickly?
Well, benzodiazepines bind directly to the GABA receptors in the brain. And GABA is the primary inhibitory neurotransmitter.
The brakes.
The brakes, yes. When the benzos bind to those receptors, they open chloride ion channels, which just floods the neurons with negative ions. This hyperpolarizes the cells, making it incredibly difficult for them to continue firing.
It essentially slams the brakes on the chaotic electrical activity almost immediately.
You got it.
But breaking the active seizure is only step one. Keeping it broken is step two.
Yes. Once the benzos have stopped the acute crisis, then you follow up with a longer-acting maintenance anticonvulsant. Drugs like phenytoin, known as Dilantin, or levetiracetam, known as Keppra.
And those are loaded into the system to stabilize the neuronal membranes and prevent the seizures from coming back.
Exactly.
Since you brought up phenytoin, that is a classic NCLEX test point. Phenytoin has a notoriously narrow therapeutic index. The magic numbers to remember are 10 to 20.
Yes. Burn those numbers into your brain.
Seriously, if the blood level drops below 10, the patient is undermedicated and at high risk for another seizure.
Right?
But if the level climbs over 20, they become highly toxic. They present with neurological deficits like severe ataxia, nystagmus, and slurred speech. As the bedside nurse, you are the gatekeeper for those lab values.
Absolutely. If the morning lab results show a phenytoin level of 26, you hold the drug and notify the provider immediately.
Right. It's a delicate balancing act. You are constantly monitoring the therapeutic range to keep the patient safe from both the seizures and the medication toxicity.
Yep. So the benzos do their job. The physical convulsions stop. The patient is breathing again. But anyone who has managed a seizure knows the patient doesn't just wake up and ask for a sandwich.
Oh, definitely not. The postictal phase is its own complex clinical beast.
It really is. The postictal phase is the recovery period. The brain has just run a marathon at a sprint pace, and the systemic lactic acid buildup from the tonic-clonic contractions leaves the muscles profoundly sore.
So when you're assessing them during this phase, they're going to be deeply exhausted, often completely somnolent, and very difficult to arouse.
Yeah. And when they do open their eyes, they are frequently confused, irritable, or even agitated because they have no idea what just happened or where they are.
Right. Your job is gentle reorientation. You assess their ABCs, obtain a fresh set of vital signs, and honestly, you just allow them to sleep. Their brain desperately requires rest to reset.
But while allowing them to rest, you maintain an eagle eye on their respiratory drain.
Good point, because we just pushed IV benzodiazepines.
Exactly. And those are notorious central nervous system depressants. You're letting them recover, but you are not dropping your guard. And simultaneously, the nursing focus shifts from emergency response to playing detective. We have to figure out the underlying cause.
Right, this is where we gather the diagnostic puzzle pieces. The very first action, which is an independent bedside nursing intervention, is a point-of-care blood glucose check.
Yes, the finger stick.
Why is a quick finger stick our immediate priority over, say, rushing them down to radiology for a CT scan?
Well, because the brain relies entirely on glucose for fuel. Severe hypoglycemia is a highly common and completely reversible cause of seizures.
Wow, okay.
If the brain runs out of glucose, the neurons cannot maintain their stable resting potential and they just begin to misfire chaotically.
So if their blood sugar is 30, you don't need a complex multi-day neurological workup.
No, you need to administer 5V50 to restore their cellular fuel. It is the easiest cause to rule out and the fastest to fix.
I love that. Okay, so once we rule out blood tests, the provider will likely order a comprehensive metabolic panel. We always look closely at the electrolytes, specifically sodium. Can you break down the actual mechanism there? Like, how does severe hyponatremia physically trigger a seizure?
It comes down to osmotic fluid shifts. Sodium regulates the water balance in the body. If the sodium concentration in the blood drops dangerously low, the blood becomes dilute compared to the intracellular fluid of the brain cells.
Okay, so osmosis kicks in.
Exactly. Through osmosis, water rushes from the bloodstream into the brain cells to try and balance the concentration. This causes the neurons to physically swell, a condition called cerebral edema.
And swollen, waterlogged neurons become highly irritable.
Yes, their electrical thresholds drop and they begin to misfire, triggering a seizure.
That structural understanding makes the lab values mean so much more than just numbers on a screen.
It really does.
So along with electrolytes, we send off a CBC to look for elevated white blood cells indicative of an infection, like meningitis, and toxicology screens to check for drug withdrawal or overdose.
Right. And from a radiology standpoint, we anticipate orders for a stat head CT scan or an MRI to identify any structural abnormalities.
We need to see if there's a physical mass pressing on the cortex, like a brain tumor or an abscess.
Exactly. We're looking for ischemic strokes or a bleeding aneurysm. Imaging gives us the structural map.
And finally, we map the electrical activity by preparing the patient for an EEG, an electroencephalogram. They paste the electrodes all over the scalp to read the brain waves. But there's a crucial nursing teaching point for the NCLEX and bedside prep here. No caffeine for at least 8 hours prior to an EE.
Yes. Caffeine acts as an adenosine receptor antagonist. It's a powerful central nervous system stimulant.
Right.
The goal of an EEG is to observe the brain's natural baseline electrical activity to pinpoint the seizure focus. If you allowed the patient to drink coffee or soda before the test, you are artificially stimulating the cerebral cortex.
Which alters the brainwaves.
It completely masks the true baseline and renders the diagnostic test highly inaccurate.
I just love how this entire framework empowers the nurse. You know, when you first witness a patient seizing, it feels like pure chaos. But when you understand the pathophysiology, you transition from being a terrified spectator to being the manager of the emergency.
You really do. You systematically control the environment.
Right. You protect the airway using gravity, you administer lipid-soluble meds to break the GABA failure, and you gather the exact diagnostic puzzle pieces the neurologist needs. You are actively driving the care.
And that is the essence of clinical judgment. It's the ability to take the science you learned in a textbook and apply it with steady hands to save a life.
Beautifully said. Let's summarize the absolute must-know takeaways for everyone listening. First, the golden rule. Never leave the actively seizing patient.
Never.
Second, protect that airway by immediately turning them on their side to let gravity prevent aspiration. Third, have your seizure precautions set up before the emergency strikes, suction checked, oxygen ready, bed padded.
Yes, mise en place.
Exactly. Fourth, watch the clock and time the seizure. And finally, recognize that the 5-minute mark signifies status epilepticus, which is a life-threatening emergency requiring airway protection and fast-acting 4V benzodiazepines.
Mastering those principles ensures you'll be a profoundly safe and effective nurse during a neurological crisis.
Before we wrap up, we want to leave you with a thought regarding the emotional weight of neurological care. We focus heavily on the physical interventions, the oxygen, the IV pushes, the padding, but consider the patient's experience.
Yeah, that's so important.
A patient waking up in the postictal fog is entirely disoriented. They have lost time. They have lost complete autonomy over their own body, often in front of total strangers, and they may be lying in their own incontinence. It is an incredibly terrifying and vulnerable state.
It truly is.
As a nurse, your calm, steady presence in that fog, the way you speak to them, the way you protect their dignity, the way you hold their hand and assure them they are safe, is just as much of a critical intervention as the lorazepam you pushed. Never underestimate the profound power of your presence at the bedside.
I couldn't agree more. The science keeps the patient alive, but the human element, the compassion, is what actually helps them heal.
Absolutely. Well, that brings us to the end of today's session. Thank you for doing the work to elevate your nursing practice. Please go watch the video version on YouTube, hit that like button, subscribe, and leave us a comment about what clicked for you today. And be sure to visit supernurse.ai for incredible, practical resources designed to help you become the super nurse you were born to be. Catch you next time.